Hello and welcome to this session on evidence-informed public health and the role of epidemiology in generating scientific evidence for policymaking. In this session, we're going to look at what is evidence-informed public health and how is it different from the older concept of evidence-based public health. Why is scientific public health evidence important to include in the policy-making process? The key contribution of epidemiology in general to public health. Key debates within epidemiology about how to tackle contemporary public health issues. How and why epidemiological thinking is evolving to address current public health issues. You came across this in the first year. Evidence-based public health can be defined as a public health endeavour in which there is an informed, explicit and judicious use of evidence that has been derived from any of a variety of science and social science research and evaluation methods. This definition highlights two aspects of evidence-based public health: the use of a particular type of evidence and the need for clear reasoning in the process of appraising or summarizing and interpreting the evidence we get from research studies. In contrast, evidence-informed public health is the process of distilling and disseminating the best available evidence from research, from context, the wider political, social, economic and public context, and experiences both from professionals and lay publics, the general public, and using that evidence, all of that evidence from all of those sources to inform and improve public health practice and policy. Put simply, it means finding, using and sharing what works in public health. So what's the difference between evidence-based and evidence-informed? Now, I hope you can see one is about being based on evidence and the other is about being informed by evidence. And so what evidence-based public health, that concept, was saying was that only or mostly 90% plus of a decision should be based on scientific evidence. No other factors should be taken into account, and only the scientific evidence is the only important thing or the most important thing. In contrast, evidence-informed public health is a concept that says scientific evidence is one important source of evidence, not the only important source. It needs to work with and be complemented by evidence from community views, from political views, from the wider social, cultural and economic aspects of a society, and that all needs to feed in alongside things like the financial aspects of a policy and whether our policy is acceptable to local communities and whether the professional consensus of people working on the ground trying to deliver services and projects and programs around public health feel that it will be an important way to support and improve public health and well-being. So why do we do evidence-informed policymaking? It's a way of learning from experience. Rather than using trial and error, we're going to use evidence from scientific sources and the wider experience of professionals and the public to make policies more effective, to help improve health and well-being in a cost-effective, cost-efficient way. We want to use money wisely. We don't want to waste it. We want to try and get as much out of the money we spend in terms of improving and protecting people's health. And we also want to make decisions in a more neutral and objective way, that while political and social factors are taken into account, we do need evidence that is more neutral, more objective, that looks at whether certain types of policies work better than others. An example of this in the US, but also occurs in the UK, is around teaching sexual health education to young people, particularly children around the ages of 8 to 12 years old. And in the US, there is such a strong movement that one of the key approaches that is used in sexual health education is to teach an abstinence-only method of sexual health management. So instead of giving children a range of options around how sexual health can be looked at in terms of relationships, and how relationships are important and how relationships should be managed, and alongside that looking at the role of contraception such as condoms or other types of contraceptive devices. In the US, in some states, there is often a focus only on abstinence as a method of reducing sexual activity and risky behaviours in young people. In contrast, in the European context, including the UK, follow a more broader approach, recognising that abstinence, while it can work for some people, is often not the only approach that should be taught and discussed with children. They need to be aware of the wide range of contraceptive options that are there, and they need to, when the time is right, make an appropriate decision on what contraception approach they will use. And so one of the aspects of scientific evidence that has been useful in this area is that much of the scientific research evidence from epidemiology has shown that an abstinence-only approach is not effective in reducing risky behaviours and reducing teenage pregnancies. So science and epidemiology has helped to inform the debate around what kind of sexual health education we should give to children. Now remember, we talked about the policy process where we went from problem identification, issue recognition, agenda setting. Then we went to policy formulation and adoption, where we decided from recognizing the problem, what can we do about it? And so we create a number of policy options, and then we choose one of them, and then we implement that chosen policy, and then we evaluate that policy, and then we go back to see if we have solved the problem or reduced the problem, or we need to re-look at the policy again and maybe change the policy because it doesn't seem to be working in the way we want it to work. So in this context, science and epidemiology can feed into all four processes. Not just the beginning phase of problem identification, though it can feed into that part, and not just the policy formulation phase in terms of setting out what options there are, in terms of what interventions work best, in what context and what communities, but it can also help to evaluate policy and to look at policy implementation in terms of doing research that looks at how best policies and different types of policies should be implemented. So epidemiology can feed into all four parts of the policy process in the general policy process cycle. But generally, as I'm sure you've recognized, it often feeds into the first two, problem identification and policy formulation. And it's the same with the public health policy process. Epidemiology feeds into assessing population health needs and to assess the possible intervention options. And it says very clearly here, using scientific and other sources of evidence and information. And it may also help to some extent, but much less of a role in developing the detailed policy choices. And similarly to the previous policy process cycle diagram, it can also help with looking at and researching the best way to implement a policy, and also it can be used to evaluate policies. So overall, I hope you get from this discussion here that epidemiology feeds into all parts of the policy process, particularly the first two parts and the last part, but it also can have a role in the middle during the implementation phase and the detailed policy phase as well. Where does epidemiology fit in if we were looking at policies from Kingdom's policy streams model approach? Well, if you remember from the previous video lecture, Kingdom's model identified three streams, and only when the three streams intersected, the problem stream, the policy stream, and the politics stream, was policy made and was policy effective in changing actions at the national or the local level. So in this context, epidemiology can feed into all the streams: the problem stream, the policy stream, and the politics stream. It's likely to have the biggest impact around the problem stream and the policy stream than the politics stream. Remember, the problem stream is about how big the problem is. Is the problem likely to get worse? So epidemiology can feed into that. So for example, in terms of obesity policy, epidemiology can show that children are getting fatter, adults are also getting fatter. It's becoming a bigger and bigger problem, and this is going to have an impact on the wider society in terms of healthcare costs, productivity costs, in terms of people dying younger, not being able to work longer. So epidemiology can feed into the problem stream. It can also feed into the policy stream because epidemiology and the research on different types of interventions and their effectiveness can feed into providing solutions of what we can do about the problem around obesity, for example. So obesity epidemiology can show that we need to focus on both diet and physical activity, and that we may also then need to look at the wider environment in which people live and work, and need to change that wider environment because, for example, physical activity is not enough, diet is an important driver, but also where people live and what they have access to are also important considerations in whether they have healthy diets and can access healthy foods such as fruit and vegetables, and whether they have opportunities like a local park or good footpaths and cycleways to allow them to do more physical activity. And it has the least impact on the politics stream because politics is about getting people's votes. Politics is about ideologies in terms of whether certain political parties and political perspectives have a view on a problem, have a view on a particular type of policy that they prefer compared to others. And this often has very little or nothing to do with scientific evidence. Just to recap, in relation to Kingdom's policy stream, it's likely that epidemiology and evidence-informed public health is likely to feed into the problem stream and the policy stream. It's much less likely to affect the politics stream. The only time, for example, in the recent COVID pandemic, we've noticed that epidemiology is feeding into the politics stream because epidemiologists and chief medical officers and scientists are taking a much more prominent role both in the political process, for example, giving regular briefings to the nation in the UK, but also in terms of social media and in terms of the research, both around getting effective interventions such as vaccines, but also about what we can do when we don't have any effective intervention. For example, the policies around physical distancing, the policy around wearing masks, and the policy around closing shops and restaurants and other kinds of facilities like gyms where lots of people meet up, including cancelling weddings and not having lots of people for other social events. Just a reminder of that visual diagram that you've seen in a previous video lecture. So remember, when it's just the problem and policy stream, which is where often epidemiology works, there won't be a change. It needs to work where epidemiology affects the problem stream, the policy stream, and the politics stream for epidemiology and evidence-informed public health to have a real effect and to change policies or to create new policies to tackle a health problem. So now let's move back to epidemiology and public health evidence. Where does public health scientific evidence come from? It comes from a branch of public health called epidemiology. Epidemiology is the core foundational science of public health. It comes from the Greek word epidemos, epi meaning upon, demos meaning the people, and logos meaning study, the study of people. Hippocrates, the father of medicine 2,400 years ago, first used the word epidemion for diseases that visit a community compared to endemion, diseases that live in a community. And so the root of epidemiology is very old. However, it's only from the 1850s and the 1900s that the notion of epidemiology as we currently practice it and think about it came into being in 1902 with a Spanish book called Epidemiologica Española, and in the 1850s with the creation of the London Epidemiological Society. And epidemiological societies were a very big deal in the 1800s because they were a vehicle for scientific thinking. That's where organisations such as the Royal Society and many other professional associations in the UK, often with the royal tag, came into being because they were places for people to come together to discuss scientific or arts or cultural topics and issues before the advent of social media and the internet and journals. So, what is epidemiology and how is it defined and thought about? Epidemiology is a philosophy, a strategy, a methodology, a way of studying a health problem. It's not in itself a body of knowledge. It is a way for us to get health knowledge. And it therefore links it into research methods and methodologies. It's an old scientific discipline, as I've said in a previous slide, going back to the 1850s. It aims at identifying the determinants of disease and health in population. It looks at risk and protective factors in particular. It uses a population approach similar to the field of demography, the scientific discipline that most closely resembles and is associated with epidemiology. And epidemiology is defined as the identification of determinants that will and hope to or can change the occurrence of health phenomena in human populations. And one of the most important ways that epidemiology looks at the world is through this analytical triad model, 3-element model: agent, host, and environment. Health can be thought of as a state of equilibrium or balance between these three factors. The host, which is us, human beings, and our genetic susceptibility, our resilience, our nutritional status, our behaviours, and our personalities and perspectives. The agent, which is the cause of the health of problem, the risk factor, the bacterial or viral microorganism, the addictive substance, the potential negative environmental factor such as air pollution or contaminated water. And lastly, the environment, the wider environment, the social, physical, economic environment in which we live. And this includes things like the availability of healthcare, the availability of good quality housing, having a good job, and all the other determinants of health. And this is an expanded model, the agent, host, environment, and vector. And what's interesting about this model is that we can actually look at, for example, air pollution through this model, rather than just looking at it in its original context, which was around infectious diseases such as malaria or TB or cholera. And in this context, we can think of ourselves as the host with our genetic susceptibility to smoking and the impacts of smoking, for example, our income, our ability to be resilient in the face of hardships, disadvantage. And we can have the agent as the cigarettes that we might smoke and that are available in our society. And we can think about the wider environment as potential to have clean indoor air policies, smoking bans, advertising bans. But it's also about peer pressure, whether our parents smoke, what's the wider society's views on smoking. And we also have vectors, and vectors generally tended to mean things like the malaria mosquito, which passes on the parasite to human beings and gives us malaria. Vectors can also be manufacturers, distributors and vendors, supermarkets and shops that sell cigarettes. So they are the vector that affect the host, the agent and the environment. And this is useful because having an analytical model, it's like a logic diagram. And all of these triads and these factors that we've looked at, agent, host, environment and vector, occur at a certain time to certain people and in certain places, and we need to consider that. So having some scientific evidence from the US from the 1950s on white communities in the US will not necessarily be relevant to the 2020s in the UK to Afro-Caribbean communities living in the UK. So we need to look at the evidence in terms of where does it come from, what place was it done, what time was it done at, and who was involved in that research, who were the participants, and do they then relate to the places, the times and the people we want to apply that knowledge to, the scientific evidence we gather. So if, for example, smoking policy was effective in the 1980s in Scotland and involved all the Scottish people, then is that policy likely to be relevant to people in England? And the likelihood is yes, because while Scotland, for example, has a smaller, less diverse population, a smaller number of ethnic minorities from Afro-Caribbean and Asian communities compared to England, which is more diverse, they are pretty similar in terms of the social, cultural, legal, political, economic and environmental context, and the 1980s are not too far from the 2020s, so therefore we should be able to apply that. Now, of course, if we had research from the 2000s and the 2010s, that would be even better, but we, in this example, the place is fairly close to England, so Scotland and England are next to each other. The time is not too far distant. The way people lived in the 1980s is not that different from how we live today in the 2020s, and the people are very similar in Scotland to what they are in England. So what is epidemiology currently used for? It's used for defining, diagnosing, characterizing and classifying different diseases. Many of the diseases that we know about, for example, malaria, TB, cholera, were defined and diagnostic tests developed through epidemiology. And the way we classify diseases has also developed through the research work done through epidemiology. It helps to work out the causes of disease and develop an explanation for why diseases occur in some people and in some places and not others. It helps to identify and define risk and protective factors for a disease. It helps to identify the distribution of risk factors in a population, which community groups, which subgroups, which parts of the population are more at risk than others and why. And it helps to identify the importance, the level and strength of relationships between diseases and risk factors to work out which risk factor is the most important. For example, in relation to obesity, we know that diet and what we eat is the more important risk factor compared to physical activity. They are not equal risk factors. Diet is the much bigger risk and influence on getting obesity than physical activity and not doing physical activity. And lastly, it helps to identify and develop interventions to tackle disease and reduce or prevent risk factors. And so classical epidemiology and 21st century epidemiology are slightly different. In classical, what used to be called the modern 20th century epidemiology, there was a focus on communicable disease outbreak control and surveillance, monitoring prevalence, incidence and trends in social, demographic and geographical distribution of diseases and conditions, identifying and quantifying disease risk factors, evaluating surgical and medical treatments mostly. But in the 21st century, we're focused more on going beyond monitoring to support and inform public health needs assessments that inform policy and decision making, using computer modelling to look at how disease is spread and the risk factors change in a community or a population. And you can see that through the recent COVID pandemic, where computer modelling was used to look at how quickly the disease would spread in a population. Evaluating public health and health and social care interventions, programs and services within and across communities, and disseminating critical appraisal skills so that the skill to scrutinize and look at scientific research evidence from epidemiology is a more common set of skills than in the past, so that a wider set of people not involved in epidemiology but that do public health can also look at and critically summarize and appraise research. Many people can see epidemiology as a very confusing thing, and that's not helped by the current news media, where you get reports saying a research study today has found coffee causes cancer in children. And then the next day you find another study has found that coffee is good for the heart in men. And so you're thinking, hang on, one study yesterday said coffee causes cancer, and today it's saying, oh, it's good for heart disease and it's good for men and we should drink more coffee. So which is true? Is it bad for children and good for men? Is that true? Or is it bad for everyone? Or is it good for everyone? Or is it not really an important factor at all compared to all the other risk factors that people face? So it's really important when looking at epidemiological evidence that we understand and can scrutinize it and be critical of epidemiology and be able to look at the strengths and limitations of different types of study designs and different types of research and the findings from that research. But we will always have this issue in epidemiology. It's not going to go away because populations change. The risk factors are changing subtly or in big ways. And therefore, the causes of disease are changing. The causes of obesity, the causes of heart disease can change over time. As we change our behaviors, we change our lifestyles, we change the kinds of things we eat, the kinds of behaviors we take part in. So all of these things mean that the causes of disease are not static. yes, there's many things that do stay the same: diet, physical activity. But what kinds of diet, what kinds of physical activity, that information, that evidence is likely to change because the types of things we're eating change in big and small ways. So one of the weaknesses that people have identified because of this contradictory nature of epidemiological knowledge and evidence and published research is that often we're not good at finding out the causal mechanisms, the biological mechanisms of how things work. Now, we do have a good understanding of smoking and lung cancer, but often for things like obesity, for things like heart disease, we're still not clear about all the risk factors for heart disease. We recently, over the last 10 years, have realized that air pollution is actually a big, important risk factor for cardiovascular disease as well as respiratory illness, and that was not so obvious 10 years ago, that air pollution can impact on the heart and on the blood vessels. So one of the criticisms of epidemiology has been that it's a bit of a black box where we don't understand how things affect diseases. We know what the risk factor is. For example, that having a healthy diet leads to improved cardiovascular health and lower levels of cardiovascular disease, but we don't know exactly what elements of the diet and in what combinations really helps to improve cardiovascular health and reduce cardiovascular disease. And the other problem has been that most research in epidemiology focuses on one risk factor or a few risk factors, and often for many key diseases there are many, 5, 10, 15, 20 key risk factors, all of them working together in combination, interacting with each other, that then leads to a disease. And so we need to understand the interaction between risk factors, not just what the risk factors are. And lastly, there has been an over-focus on biological and individual level factors at the expense of community and societal factors, the wider determinants of disease. We've generally focused on lifestyle, behavior, those aspects of and those risk factors of people, rather than the wider social, economic and cultural factors that also have a big influence on health and well-being. And this has been addressed by reorientating epidemiology to take a more eco-social, eco-epidemiology approach, with more of a focus on both the biological and societal causes and mechanisms of disease, a focus on multifactorial and multi-level causes, so both risk factors and many risk factors, as well as the different levels that risk factors can act. It's a focus on more societal factors being more important than the individual level factors in causing disease or in improving health in populations. And again, also focusing on population level interventions rather than individual level interventions. So rather than focusing on people's diets and physical activity, how can we change the wider society? What can we do by increasing cycleways, improving footpaths, creating shade, increasing access to parks, creating bigger parks? How are these population level interventions likely to have an effect on people? And are these population interventions likely to be more effective and more useful and better at reducing, for example, obesity and cardiovascular disease and improving mental health and well-being, rather than individual level interventions such as cognitive behavior therapy or counseling or motivational interviewing or any of the individual level health education, health promotion interventions that we can think of? So what are the challenges for us in the 21st century? So we need to guide and promote ways of using research and analytical methods that can tackle the broader set of bigger problems that are facing public health. We need to evolve and disseminate and share new methodologies and approaches to doing epidemiology so that we can be more focused and we can be more relevant to politicians and policymakers around the public health agenda. We need to make people better at evaluating and appraising epidemiological and scientific evidence so that we are a more informed society. and that we use an approach that is evidence informed rather than one that is just focused on political and social and cultural factors. That evidence does play an important part and should play an important part, but that needs us all to be good at telling what is good research and what is bad research or poor quality research. We also need to be better at working out what are simple causes and contributing factors and risk factors, and what are the complex causes and contributing factors. We need to look at more socio-economic, political, distal explanations for the causes of disease and ill health and the risk factors for disease, rather than the biomedical proximal factors related to individuals. We need to also focus on subjective information and data and health outcomes such as well-being, and not just be over-focused on physical health and disease. We need to take a life course approach, recognizing that risk factors change over time and affect people differently at different times in their lives and at different ages. And we need to be better at evaluating complex public health interventions, because community-based public health interventions are much more complex than clinical interventions such as taking drugs or having a vaccine or doing a surgical procedure. And lastly, we need to be better at recognizing the role of genes and the interaction between genes and the environment. So the influences on epidemiology are many. We can think of them at a number of levels. The way we think about epidemiology, the scientific paradigm, the worldview, the perspective of the epidemiology and its role as a science in public health. And it's also about the social values we as professionals, as public health professionals, as epidemiologists have, and how that informs how we look at what happens in society and how something affects something else. We also need to be aware of the social determinants, but we also need to look at new techniques such as molecular and genetic epidemiology and how that can tell us and how that can inform whether X causes Y, whether obesity or diet and physical activity lead to heart disease. And then we need to also be better at looking at what the population health implications of that are and what the policy action needs to be. This means that epidemiology and research is not an objective process, but it is influenced by social and cultural values, and it is influenced by other disciplines and concepts, models and methodologies that come from toxicology, medicine, environmental science, sociology, and maybe even political science that feeds into the research process, that feeds into the different types of studies that we might undertake in public health, and that influences what kinds of aims and objectives, hypotheses we look at, what kinds of methodologies we use, and what kinds of theories and models and frameworks we use to inform policy using epidemiology and public health evidence. And you can see here in this diagram that epidemiology starts with concepts and definitions. It moves on to frameworks, metaphors and scientific models of how the body works and how we think risk factors influence diseases. We then develop a hypothesis, aims and objectives, which leads us to think about what kind of study methodology we'll use. We do our research, we find relationships and findings and associations, we develop theories and also mathematical models, and then that feeds into the policy framework, and we then feed that into the policy cycle. So let's look at an example here that gives you a life course understanding of lung disease in adults. So we start with lung disease in adults, and we want to understand why people might get lung disease as adults. And one of the key factors is occupational hazards. Working in a chemical factory, working in a woodworking shop where there's lots of dust, woodworking dust, working in a coal mine, working in some other type of activity where a lot of dust is thrown up, can have a big effect on lung disease in adults. But air pollution also has an effect. So does diet in terms of maintaining good lung function. And of course, smoking has an impact on lungs and lung function and hence lung disease. But all of these things, occupational hazards and air pollution exposure and diet and smoking, are related to a person's income and their socioeconomic status and their education level. So that socioeconomic status impacts on what kinds of jobs those people do. So they're more likely to do more hazardous, dangerous jobs where maybe the company is not providing good protective equipment. It's also likely that those people with low socioeconomic status, with low incomes, are living in poorer areas, which are maybe likely to have more air pollution, for example, near motorways or large roads, or maybe near an airport or a factory. And they are also, because they're more likely to be stressed out and worrying about money, to have poorer diets and more likely to smoke because, again, the stress, they're turning to smoking and drinking to alleviate the stress they might be feeling because of their financial insecurity and the hazardous job that they are involved in. And the lower socioeconomic status is likely to be linked to poor educational achievement than when they were younger, which is of course linked to the poor socioeconomic status that they lived in when they were a child, the lower socioeconomic status of their parents. And of course that lower or poorer childhood socioeconomic status will likely link to them being exposed to more air pollution, maybe being exposed passively to smoking from their parents, to having poorer nutrition because their parents did not have the money to have a good quality diet. And these things might lead to more childhood chest illnesses. And these childhood chest illnesses and the impact of air pollution and passive smoking and poor nutrition may have been affected by poor growth in the uterus before they were born during pregnancy, which might lead to poor lung development, which when they were born and when they are young, 1 year, 2 years old, as infants, they have more respiratory infections, which again leads to more childhood chest illnesses. And all of these may be linked to their genetics and their genetic predisposition to poor lung development, which then impacts on respiratory illnesses in childhood and then of course also respiratory illness and disease in adults. So you can see here that there are a complex set of factors leading to lung disease. It's not just smoking, it can be a range of factors across the life course, from being in the uterus during pregnancy, before a child is born, to after a child is born, and as they grow up and become adults. Just following up on that, your mum and dad have an influence on you. You're born, you're conceived, and then you age, and that leads to a range of different impacts and exposures across the life course, which leads to a range of different types of illnesses and diseases, and which obviously finally lead to death. And these are all working through an interaction between the gene and the environment, your genes and the wider environment you live and work in. It relates to your susceptibility, which links to your genes and to the environment in terms of exposures, what are you exposed to in the wider environment. And it then also links to your adaptation, both your genetic adaptation but also your personality, which some of it comes through your genes, your personality and your ability to be resilient and to resist the negative factors in your life. And of course the exposures from the environment are likely to lead to certain types of diseases, and so it's the adaptation to those diseases that you may have which also leads to how you are going to deal with the disease and how you're going to cope with the disease, how your health and well-being will be affected by a disease. So you can see here again a different way of looking at it, but again a life course approach and multiple factors affecting both diseases and deaths, mortality and morbidity. And one of the other things we looked at was how risk factors affect at different levels. So there's different risk factors, but they also affect people at different levels. So we can have effects at the genetic level, the molecular level, the cell level, the organ level, the organism level, all at the individual level. And then we can have an impact at the level of life, flora and fauna, plants and animals, the human population, on an evolutionary scale, and the geophysical cycles of the planet that we live on, planet Earth. And that impacts on the social systems, the network web of society, the economic systems, the social systems, the political systems that we have. And then that impacts on our culture in terms of ideologies, values, and our perceptions of the world. And to give you an example of this, we can look at smoking and air pollution. And so smoking and air pollution both affect people at the genetic level, at the lung cell level, at the lung respiratory system level, and at the individual as a whole person level. And then in terms of the network of life, air pollution affects plants and animals. So it has a negative effect. The air pollution we produce from cars, from factories, from power plants has a negative effect on plants and animals, not just human beings. It also, air pollution and the industry related to air pollution also has an impact on the geophysical systems of the planet. And at that level, this then leads into the network of society, the social level, and all of these things. Air pollution is related to poverty and deprivation, the social infrastructure in terms of free healthcare, social welfare systems, employment, transport infrastructure, the tobacco industry, the car industry, government policies on air pollution, on smoking, and taxation, and the impact of how taxation on tobacco increases revenues and monies that governments can use to do other things. So what kinds of transport we have, what kind of car industry we have, what kind of social infrastructure and employment we have, all has an impact on how air pollution and smoking impact on people. And then at the cultural level, there are issues around smoking. So for example, currently, whether smoking is not an acceptable thing at the population level, you can smoke as an individual, but you should not spread your smoke or affect other people who are not smokers around you. But in the past, if you remember, in the 1950s, 60s, 70s and the early 80s, people were allowed to smoke in pubs, they were allowed to smoke in workplaces, they were allowed to smoke on buses, in cars, on trains, in aeroplanes. People could smoke, and that has obviously changed now. So the cultural values have changed around smoking, so we no longer find that acceptable for people to be smoking in workplaces or in cars or in trains or in aeroplanes. And in terms of political values, the current liberal democratic political ideologies that we have, we tend to say smoking values at the individual level are acceptable, but at the population level they're not. But air pollution, in contrast, we accept it at the population level. So even though, for example, you and I may not use a car, and we may not use a lot of public transport either, and we may still use power plants and other things to get our electricity and gas. So at the population level, it's acceptable for air pollution to be produced. Yes, we try and reduce it, but there's a certain level of air pollution that we all accept and we're happy to accept or tolerate. But air pollution at the individual level, when I live next to a motorway or when I am affected by a factory, then that is not acceptable, because then we will fight and lobby and protest and move cars, for example, from a busy road away from where we live, because we find that not acceptable, even though at the population level it is legal for companies and for cars to be polluting the air at some level. And because jobs and economic growth are important, again, that's why we tolerate air pollution, because we need cars to move around in. We like cars, and also the jobs from car manufacturers is important. And the same goes for tobacco as well, that there is a jobs and growth, economic growth linked to, at least in the past, if less so in the present, with tobacco manufacturing. So epidemiology needs to look at all of these levels, and not just at one level between the smoking and the person. We need to look at why people smoke. We need to look at the infrastructure around smoking, and we need to look at the cultural values that people have around smoking. In the future, we are likely to be doing more genetic epidemiology and looking at genetic interventions at the individual and potentially at a whole population level. There is and continues to be an increase in the use of mathematical and statistical modelling of things like Bayesian statistics. There is more meta-analysis, more pooling of randomized controlled trial data so that we can look at 10 studies and their information and do a statistical analysis of all 10 studies and the participants in those 10 studies, pooling the data from existing randomized controlled trials, for example, and doing a bigger analysis to find more robust findings and better, more consistent and more useful findings for policy making and the policy process. And we are doing more evaluations of interventions to work out what are the best community-based interventions for public health. And there is still a debate about, is epidemiology about informing public health? Is it about advocacy? Is it about making the decisions? Because epidemiology is at the interface between science, policy and politics. And that's a really important point. Epidemiology is at the interface, is connected to science, policy and politics. And it has to take a balanced approach, a balanced perspective in how it fits into and does things in the policy and political arena. Some people feel that we should just inform policy. Some people we should be advocating a policy because we should be champions of public health and that we should be pushing for certain types of policies in society and not just saying, well, this works, this does not work, this works in this context with these kinds of people, it doesn't work in this kind of context with those kinds of people. And so currently epidemiology is more about informing rather than advocating, but this may change in the future. So how effective has public health and epidemiological evidence been in influencing policy making? Well, the first point is that using scientific evidence, using epidemiological and other public health evidence does not guarantee that a policy will be successful. Hopefully it is more likely to make it successful, but it still does not guarantee it. And this is because there are key real-world factors that research, epidemiological research, public health research, and other types of relevant research like sociological research do not take into account in their research, because research is always limited in some way or another. The other problem is that politicians often don't give policies and effective interventions enough time to work, because they are on a political cycle of 5 years or less, and therefore if a policy does not make change within 2 to 3 years, they are likely to start changing the policy because they feel it's not working. But the problem with public health is that often many of the changes that we want are on a 5, 10, 15 year time scale. Obesity can't be changed in 2-3 years. It needs 15 to 20 years to make a real measurable big difference in a population. So the value of scientific evidence at the moment is mixed. Yes, some have worked, some have partly worked, and some have not worked. And that's the case with all types of evidence, that some evidence is useful and leads to good policies that work. Some lead to policies that partly work, and some lead to policies that don't work. Well, I hope you enjoyed this session. I look forward to talking with you in the Apply session.